Thank you, Professor Abdullah, and thank you, Giuseppe, and the group really for giving us this wonderful opportunity every year to sort of recap on what we have learned. So I'm going to be talking about pulmonary hypertension updates specific to what we've done in the UAE, and I'll try to summarize in 10 minutes a 10-year journey. Hopefully, we'll be able to be on time. So before I start, I'd like to thank these three individuals without whom pulmonary hypertension would not have existed in this country. They laid the groundwork before I even came to this country. And I have to specifically acknowledge Dr. Ashraf Zahabi, who's actually the president of the Emirates Thoracic Society, and Dr. Mohammed Badr, who started the first pulmonary hypertension center after he came from Montreal in Canada in 2007. He came back to the military hospital. And Dr. Sabour, who's my colleague and coworker who's now gone back to the US. So this is our first paper from our registry, and we published our 1-year data. It took a long time to be accepted, so this is why it's been a little bit delayed. This was during COVID, as you can imagine, and it was presented at the American Thoracic Society meeting. And in this data, we were able to analyze our 1-year survival from our pulmonary hypertension registry. So the data is fairly similar to what you see in international registries. There's a 76% survival in patients transferred from other hospitals, i.e. diagnosed in the hospital and presenting very late. The 1-year survival was 88% in all comers, but those patients who came to us in late stages, functional class 3 and 4, 50% of the patients were like that. So unfortunately, this indicates we're getting patients referred too late for us to do much for them. And I think one of the things we've done at these forums, and supported by Dr. Abdullah and the Emirates Cardiac Society, is to try and highlight the importance of early diagnosis of pulmonary hypertension, because it is a terribly confusing disease. Now, there is an update from the European Society of Cardiology guideline. This is the 2022 guideline here, and they've updated their risk criteria. So now the risk criteria is called a 20% 1-year mortality is a high-risk patient. Now, if you think about that remarkable number, 20% mortality in 1 year, that's 10 times higher than what you get with coronary artery disease and certainly with heart failure. And the things that they tell us to do on every visit are actually quite a lot. So these are patients you cannot just depend on symptoms. You have to prospectively look for signs of right heart failure. You have to look progressions of symptoms and functional class. And one of the things that's different between heart failure and pulmonary hypertension is the presence of syncope. The presence of syncope is a very poor prognostic sign in a patient with pulmonary hypertension. It's a red flag sign, and it indicates, again, mortality of more than 20%. So a young patient with syncope and pulmonary hypertension, this is a really bad thing to have. Of course, you also have to do echo very frequently and pericardial effusion, even if it's small or large or significant. You must measure the TAPC in the right atrial area, and you have to frequently look at the hemodynamics. On average, these patients have a low cardiac index and a high right atrial pressure just before their mortality event. So I think there's a structured follow-up that needs to be done. So even with that, and 50% of our patients met these criteria, our actual 5-year survival was 76%. So we're trying very hard, but these patients do come to us quite late. Now, this is something we're very proud of. This is our most recent publication. This was just published in the Journal of Clinical Medicine. This is our 7-year data. And I won't bore you with all of this tremendous data table, but just to summarize, most of these patients were advanced functional class, very high NT-proBNP, very high pulmonary vascular resistance with low cardiac index, and more than 70% were females, but the age is also very young, 40 to 45. And because of the prevalence of diabetes and insulin resistance and COPD in these patients, there's actually an overlap where these patients actually have group 1 pulmonary hypertension as well as other secondary issues. The other component of this data on the second table is that severe disease requiring triple combination therapy in more than 50% of the patients. This is quite unusual because if you have treatment-naive patients, they usually get by with dual combination therapy. And here is the Kaplan-Meier survival curve, and as I mentioned, 75% out to 7 years at this point. We've also divided the patients based on congenital heart disease in blue, connective tissue disease in red, and idiopathic in green. The majority of our patients is actually skewed between congenital and idiopathic because of the demographics of this population. But you find typically, again, the connective tissue disease have the worst survival down here in red, less than 75%, and the highest survival are the idiopathic. So again, we do see referrals from rheumatologists, but unfortunately, those referrals are also late. So we have to be very careful about this. Now, the problem that we've identified in the guidelines is that unfortunately, as cardiologists, we make a big mistake. We give these patients low dose sildenafil and think we're giving them a proper treatment. This is incorrect and inconsistent with the guidelines. So most of the patients at first visit were on monotherapy with low dose sildenafil. That doesn't help. It really has been shown in evidence-based medicine that actually this promotes mortality. They have to be on dual combination therapy with high doses of tadalafil and endothelin antagonist in order to survive. And most of the patients were able to get them onto triple therapy in yellow here by their last visit, whether they're idiopathic, congenital, or connective tissue disease. So the right treatment is actually combination and not monotherapy. We've also participated in a scleroderma registry with our group of rheumatologists, and in about 60% of those patients with scleroderma in this registry had pulmonary hypertension. So one of the things we have to tell our rheumatology colleagues, they need to do an annual echo on every single patient with scleroderma, whether or not they have dyspnea or otherwise, because it's extremely common. 2/3 will have pulmonary hypertension, and then they should be referred for additional testing. So one of the things that's also been going on is a consensus guideline recommendation, which Professor Abdullah Shahab is also leading with us. And it's a consensus between 3 different societies. This is unique: the Emirates Thoracic Society, the Emirates Cardiac Society, and the Emirates Rheumatology Society. We're participating in a combined guideline that helps to guide the practice and diagnosis in the UAE. And I think one of the things that we've tried to highlight in this, and I'm going to repeat it today, is that pulmonary hypertension is a disease that overlaps many different symptoms, and it's tricky to many different physicians. So the red flags here are the presence of fatigue, dyspnea, and dizziness in combination in a young patient. If they don't have an explained reason for all of these 3, think of pulmonary hypertension, right? The next stage, of course, is to suspect, and then after you do that, do a proper echo and refer quickly to the pulmonary hypertension experts. The reason why, if you miss this, and it's mostly 3 years before the diagnosis, right ventricular failure and death, and as I mentioned, mortality is 20% in 1 year. So missing an opportunity is really very serious. The next point, of course, is that the patients can then get worse. They start having chest pain. They start developing abdominal distension with ascites. They have progressive lower limb edema. This is the right-sided heart failure, and heart failure as well. Now, there are some additional confusing symptoms that lead these patients to go to the wrong specialty. For example, if they have a cough, they're going to go to a pulmonologist and be treated as bronchial asthma, right? If they have syncope or arrhythmias, who are they going to go to? They're going to go to the electrophysiologist who's going to be treating them for atrial flutter or tachycardia. But in fact, the reason is the pulmonary vascular circulation and the high right ventricular afterload causing atrial stretch. So this is why it's a tricky disease, because common symptoms, dyspnea, fatigue, and chest pain, can be attributed to other disorders. Other less common symptoms, syncope, dizziness, and palpitations, are not often linked to the primary symptoms, leading to a delay in diagnosis and therefore hemoptysis, peripheral edema, and hoarseness of voice, which is like an Ortner syndrome, starts to become more common in our patients. So I want to just nail this point again. There are many confounding mechanisms of dyspnea in young patients. What is often forgotten is the one in the middle. That is the heart and the pulmonary circulation, especially in young healthy females. Anemia is often quoted as a cause. Lung disease and airway disease are often quoted as a cause, but almost always these patients are not wheezing. So we're missing an opportunity for proper diagnosis. So just to think about it as clinicians, why would any of these symptoms happen together in a young patient? Shortness of breath, fatigue, weakness, angina, and syncope, especially with exertion. And of course, if you wait too long, you start having abdominal distension and RV dysfunction. Typically, and even in many advanced countries, 2 to 3 years after the first symptoms. This is the REVEAL registry. This is from the United States Centers of Excellence. 2.8 years before the diagnosis is actually reached. So, and excuse me for keeping to repeat this many times, in the absence of signs and symptoms or risk factors for cardiovascular disease or respiratory condition, consider pH in the differential diagnosis of exertional dyspnea, syncope, angina, or progressive limitation of exercise when there's no obvious reason. Also, some high-risk patients. If a patient has a family history of pulmonary hypertension, this could be the BMPR2 mutation. If it's connective tissue disease, these are high-risk patients. If it's congenital heart disease, it's also high-risk patients. And patients with HIV and portal hypertension have a particularly high incidence of pulmonary hypertension. Now, the difference here is if you screen patients and identify them early, and this is from a French registry, If you do, and you detect them early, the survival can be as much as 64% in 8 years. If you don't, the survival is only 17%. So it is lethal to miss the diagnosis. I really want to emphasize this to the group here. So one thing we do as cardiologists is we do echoes and we interpret echoes. Can you diagnose pulmonary hypertension based on the TR velocity? The answer is absolutely not. And this is actually an update and a clinical pitfall from the guidelines. So this clinical study, this is actually evidence-based medicine, proved this point. They took 600 patients with scleroderma and they subjected all of them to a right heart cath, every single one. And then they went back and looked at their echoes. In fact, 39% of these patients had a TR velocity less than 2.8, even though on the right heart cath they had definite pulmonary arterial hypertension. So that means 1/3 of the patients would be missed if you only did the echo. And at the expense of that, you had 16% of patients had a TR velocity of 2.8 who did not have abnormality on the right heart cath. So the answer is it's the right heart cath that's definitive, not the TR velocity. But there are some solutions. Here is the solution. You do a very detailed right heart echo. In other words, if you look at this echo, what's missing here? Okay, you have mild TR, normal LV function, left atrial diameter is 3.6. You don't see anything about the TR. So this patient has a dilated RV, the TAPC is 1.7, and the peak tricuspid velocity is 4.4. So this is a problem. If you don't look at the RV systematically, you're going to miss these patients. And this is extremely dangerous because the other specialties are depending on us to make the diagnosis. So obviously, you're cardiologists, you know exactly what this looks like. This is the D-shaped septum, this is the dilated RA, this is the small left atrium, and of course the RV is markedly dilated. However, I have seen echoes look like this and the TR velocity being unreported or underreported, and they don't tell you that the patient has right ventricular dysfunction. This is a very serious mistake. This is actually the echo of the same patient, right? If you look at this TR velocity, you can make it up. You can say, well, it's 300, or maybe it's 200, or it's maybe, I don't know, I'm not sure. It's not a good envelope, right? But you know for certain that this patient has a dilated RV and a dilated D-shaped septum. So what are you going to say? Pulmonary hypertension is unlikely, discharge the patient, repeat more echo measurements, require a cardiac cath. It's fine, we'll check again in 4 to 6 months. Well, the right answer is do more measurements, because this is a high-risk patient and they have some features that are telling you that the right ventricle is dilated. So the technician went back and got a better coaxial Doppler envelope, and you now see that the RVSP is 77, when in fact it would have been obvious even without the TR velocity. So the guidelines, the ESC guidelines, have been updated, and this is a key component for all of us to remember. If there is right ventricular eccentricity index, i.e. the flattening of the septum, a dilated right ventricle, basal ratio of more than 1, if there's a dilated pulmonary artery and or RV outflow tract notching in the pulse Doppler, or the IVC and the right atrium are dilated, i.e. any dilatation of the right ventricular structures or right atrial structures of the pulmonary artery, you cannot exclude pulmonary hypertension, and you have to state that categorically in your echo, even if the TR velocity is not measurable or less than 2.8. Do not be tricked by the TR velocity. You must report these other findings, and this was emphasized again in the updated guideline over here. This is the 2022 guideline. It's very clear. If you're looking at the right ventricle or trying to report a patient with right ventricular dysfunction, there are 16 essential elements. If you don't have the 16 elements, you have not properly given this echo due justice, and you may miss a very serious patient who has a high risk of mortality. So not only the velocity, the right atrial area measured in the 4-chamber view, you have to look at the RV dimensions, you have to describe the eccentricity index, you must look at the right ventricular outflow tract and describe the notch. So the final part that I want to emphasize is the pulmonary hypertension is a hemodynamic definition. And in 2022, the ESC ERS guidelines were updated, and they give you a lot of details here. If you're going to do a right heart cath, do not just measure the pressure. It is mandatory to measure the pressure, to measure the wedge, to measure the pulmonary vascular resistance and the cardiac index. It is a must, it is not optional. It has to be done because you cannot determine the treatment if you do not get these measurements. And if you don't, then you're just getting an expensive echo. So, very, very last words. Confirming the diagnosis of pulmonary hypertension, right heart cath is the gold standard test. It's not just for pressure, but for hemodynamic calculations. The wedge pressure tracing is critical, and this is how you have to measure it. And there are many pitfalls, and therefore, it's recommended that right heart cath be done in experienced centers with a complete set of hemodynamic measurements. And thank you very much.